Welcome back to the deep dive. We grab stacks of complex material, we tear away all the unnecessary jargon, and we cut right to the core knowledge you need. Today, we're diving into a really critical junction in modern healthcare leadership. We're looking at that friction point between clinical governance and, well, leadership negotiation. And this deep dive, it's not just about defining terms. Our mission is to give you a kind of comprehensive shortcut, a shortcut to understanding how these major organizations, from huge urban hospital networks to systems with far fewer resources, ensure continuous, measurable quality. We're going to lay out the structures of accountability and then, and this is the important part, show you the strategic tools leaders actually use to drive profound change.
And that intersection is, that's where leadership really happens, isn't it? The timing for this is just so vital. Healthcare systems everywhere are dealing with just an unprecedented level of complexity. You've got rising regulatory demands, high patient expectations, and, often political inertia. So to really move the needle, leaders have to be masters of both things, establishing the rigorous standards and strategically navigating all the human and financial dynamics.
Our source material today is a set of comprehensive lecture notes. It synthesizes decades of evidence-based frameworks and practical tools, all tailored for global healthcare professionals. It's dense, yeah, but we've pulled out the actionable strategies that will stick with you.
Okay, so let's unpack this. We should probably start with the foundation, clinical governance. When we talk of clinical governance, we're talking about so much more than just a stack of policy documents. Conceptually, you should think of it as the ultimate promise an organization makes to its community.
That everyone, from the CEO right down to the bedside nurse, is held accountable for continuously improving the quality and the safety of care.
That concept was famously formalized in the UK back in 1998 with the document, A First Class Service. It defined it as the framework for accountability. But if we connect this to the bigger picture, the World Health Organization helps broaden that view. Governance isn't just policy, it's the full ecosystem, the structures, the processes, and the embedded culture.
The culture, right?
That's what guarantees care is safe, effective, and patient-centered, and that the organization systematically learns from everything it does.
Okay, so here's where we get that organizational map of excellence. To make that accountability real, governance is broken down into these interdependent domains, often called the 7 pillars. We should probably zero in on, say, the 4 pillars that really define whether a system is truly excellent or if it's just, compliant. Let's start with clinical effectiveness. This is the non-negotiable core. It means ensuring that every single intervention achieves its intended outcome, all based on the best available, globally vetted evidence. This is that constant pressure point for leaders, isn't it?
It is. How do you make sure that cutting-edge national guidelines are actually being implemented in a busy ward and not just sitting on a shelf somewhere?
Exactly.
And building right on that, we have risk management. What's so fascinating here is that mature governance systems prioritize being proactive, not reactive.
So it's not just about looking back at what went wrong.
Not at all. It moves way beyond mandatory incident reporting. It demands tools like failure mode and effects analysis, or FMEA. And FMEA is so critical because it forces leaders to stop analyzing past mistakes and start predicting where the system will break next. That lets you intervene before harm occurs. That shift is immense.
Okay, so the third key pillar is patient experience and involvement. This is where the whole system is really anchored to the person receiving the care. It transforms care from something that's done to a patient to something that is done with them. This is the domain of shared decision-making, feedback loops, and using patient-reported outcome measures, PROMs.
And PROMs fundamentally shift the power dynamic. They measure success from the patient's subjective perspective. Did my quality of life improve? Which means leaders now have to satisfy clinical metrics and these documented patient outcomes.
Right. And the last one?
The final one we should focus on is learning effectiveness. This isn't just about, ticking a box for continuing professional development. It's the whole organizational commitment to growth. It's fostering a non-punitive culture where staff feel safe to report near misses, where mistakes are seen as data points for system improvement.
So once you have these standards, how is accountability actually enforced? Where does the buck truly stop in one of these massive interconnected health systems?
Accountability in governance is intentionally tiered. There are 4 distinct levels. At the very top, you have the board level. They don't deliver the care, but they hold the ultimate responsibility.
For the whole strategy.
For the quality strategy, for ensuring there are adequate resources, and for actively fostering that safety culture we just talked about. Then below that, you have the executive level. They're accountable for implementing the structures, putting the frameworks in place, allocating the budget. Then you get to clinical leadership.
The chiefs of staff, the manager.
Exactly. They're accountable for setting and enforcing the standards within their domains, credentialing, running peer reviews.
And crucially, this structure goes right down to the individual practitioner. Every single clinician, therapist, technician, they all bear personal, daily accountability for the quality of their own practice.
For adhering to protocols and being diligent about reporting incidents, it has to feel like a reality, not just a set of rules from on high.
Just for context, it's worth seeing how this plays out globally. The UK model, for example, is rooted in that statutory duty we mentioned, with powerful oversight from the CQC.
Right, the Care Quality Commission.
Whereas the US model is more of a multi-layered web. It relies heavily on private organizations like the Joint Commission for Accreditation, plus federal oversight, and then the hospital board's own fiduciary duty.
What's truly fascinating, though, is the need for radical adaptation, especially in, say, the African context.
Because you can't just copy-paste the model.
You can't. Given the reality of resource constraints and infrastructure gaps, a Western model just won't work. Effective governance there often requires integrating deeply localized community engagement strategies. It's far more complex and localized.
And that structural reality, the gaps, the resource limits, the different priorities, that's precisely why the rigid mandate of governance requires the flexibility of a negotiation.
Absolutely.
Governance gives you the standards. Negotiation gives you the strategic influence to actually implement them when people, politics, and budgets collide.
And that's the perfect transition. Because in healthcare, success isn't defined by a single transaction. It's defined by sustained, systemic change. Negotiation in this field is about strategic influence, maintaining relationships, and facilitating complex change. Leaders are constantly negotiating.
Everything, right. Resource allocation, interdepartmental cooperation.
Engagement with external forces like regulators and payers, everything.
So to tackle this, leaders often turn to the gold standard, the Principled Negotiation Framework, which came out of the Harvard Negotiation Project. This framework is a roadmap for achieving what they call wise outcomes.
Agreements that are durable and fair.
Exactly. While preserving or even strengthening relationships. So let's look at the 4 principles through a clinical lens. First one, separate people from problems. This is so challenging in healthcare because the people are the experts. Their professional identity is all tied up in their approach. You have to learn to criticize the plan, not the surgeon.
Principle 2, focus on interests, not positions. A position is the demand. I need 3 more nurses. An interest is the reason for it. I need them to safely manage patient acuity and reduce burnout.
So you have to keep asking why.
Constantly asking why and why not until you uncover those underlying needs. Once you expose those, you often find shared ground, even if the positions seem totally opposed at first.
Then principle 3 is the creative stage. Invent options for mutual gain. And this has to happen before you evaluate them. It's so easy to assume negotiation is zero-sum in a strained resource environment, but brainstorming, looking for diverse forms of value, can open doors.
Yeah, maybe it's not just about money. Maybe one department gets new equipment, but another gets more autonomy on their scheduling. You have to expand the pie.
And finally, number 4, insist on objective criteria. This grounds the whole discussion in fairness.
In a clinical setting, this means decisions have to be based on legitimate standards. Things like evidence-based clinical guidelines, industry benchmarks, or just shared principles like patient safety.
It takes the personalities out of it.
It anchors it firmly in verifiable, neutral facts.
Okay, but the critical prep step that underpins all of this is understanding your beat TNA, your best alternative to a negotiated agreement. What do you do if this all just collapses?
Knowing your BTNA, and more importantly, knowing the steps you've already taken to strengthen it, gives you tremendous power. But that's only half the story.
You have to know theirs too.
You absolutely have to critically assess the other party's BTNA. That insight gives you a clear window into their flexibility. If you know their alternatives are poor, you know they have a much greater interest in collaborating with you.
And conflict is just inevitable. I mean, you have all these highly trained specialists with different views on patient pathways, resources, risk. It's messy.
But effective leaders see conflict as an opportunity for system improvement, not just a problem to be solved.
Right. And we should probably mention how leaders need to shift their negotiation styles strategically. While there are 5 styles, the key takeaway for a governance leader is knowing when to shift gears. Collaborating is the ideal style for these big, complex quality improvement initiatives where you need sustained buy-in.
But there are times when collaborating would be dangerous. The competing style, being highly assertive and uncooperative, is absolutely necessary when emergency decisions are required to protect immediate patient safety.
If consensus means a delay that could harm someone,
Then the governance mandate requires the leader to insist on the safest protocol, period, even if it means overriding dissent in that moment.
this brings us right to the integration point, the governance negotiation nexus. This is really the heart of our deep dive. Governance sets the standards, the what's safe, effective care. Negotiation provides the how, the influence, and skills needed to implement those standards across a complex human system.
That connection is just vital, especially for what we call quality improvement negotiations and risk management negotiations. To succeed here, leaders need specific competencies. First, they need sharp systems thinking. They have to understand how an agreement with, say, the pharmacy department might inadvertently strain nursing and cause a new risk somewhere else. You have to map the consequences.
They also need really high emotional intelligence. Healthcare conversations are high stakes. They involve life, death, professional reputation. Leaders have to recognize and manage those strong emotions, fear, pride, to stop them from hijacking the negotiation.
And most critically, they require ethical anchoring. The governance structure imposes a moral baseline. Leaders have to maintain an unwavering commitment to patient welfare.
So they have to know where the line is.
And be prepared to walk away from a consensus if it means compromising a fundamental safety requirement.
Let's make this concrete with that case study from the source material. Reducing surgical site infection, or SSI, rates.
Okay, so the governance committee identifies high SSI rates. That's the non-negotiable quality mandate. The leader, let's say the chief quality officer, has to negotiate a prevention bundle. This requires changes from everyone: surgeons, anesthesiologists, nurses, pharmacy administration, a huge group.
So how do they approach it?
Well, the strategy has to be integrated. First, they don't lead with confrontation. They build a coalition with a respected surgeon as a champion. They use compelling data, maybe surgeon-specific anonymized benchmarks, to make it tangible.
They address the core interests, right? Acknowledging the surgeon's need for autonomy or the nurse's concern about workload.
Exactly. And they invent options for mutual gain. And the whole time, it's all anchored by objective criteria, the undisputed evidence-based SSI guidelines.
That model gets even more complex when you step onto the global stage. I mean, we can't talk about implementation without recognizing how culture radically impacts these negotiations.
Oh, absolutely. What works in Berlin might fail spectacularly in Tokyo or Rio.
Take power distance. In cultures with high power distance where hierarchy is really accepted, negotiating with a mid-level manager might just be a waste of time. You have to find the person with the formal authority.
Or think about individualism versus collectivism. If you're in a collective culture, framing a change in terms of how it benefits the whole team or the hospital's reputation will resonate so much more than offering individual incentives.
And finally, communication style. That's a big one. High context cultures rely on subtle, implicit cues, while low context cultures need everything to be direct and documented.
The practical tip here is not just to Google the culture, but to engage local advisors and champions early on.
So to summarize the key takeaway for you, the learner. Clinical governance provides that necessary ethical structure and the measurable standards for excellence.
And strategic negotiation provides the essential influence. It's the mechanism to mobilize people and resources and to move that structure toward continuous improvement, overcoming all that inertia and conflict along the way.
And the framework we've covered is summarized in the Governance Negotiation Action Planning Model. The process moves logically from assessment mapping interests and culture to strategy development, building your DNA, finding champions to engagement.
Building trust before you even make the formal ask.
Then you move into the structured negotiation itself, always insisting on those objective criteria, which leads to implementation and finally a thorough evaluation that monitors the outcomes against the original governance mandate.
Which leaves us with a final provocative thought for you to consider. In healthcare negotiations, patient safety and quality are the objective criteria. Given that ethical anchoring required by clinical governance, this boundary is inherently rigid. So the question is, when does the pursuit of consensus and compromise in negotiation cross that line into compromising the fundamental ethical mandate of safety and quality? That is the constant, high-stakes question every effective leader has to continually mull over.